Hello, my name is Mark Setter, and I want to welcome you to our webinar today on bridging clinical skills with practice success. Now, every dentist certainly aspires to having clinical success, and the pathway to achieve that is rather obvious in that there are many CE programs, literature, institutes around the country. In fact, Dental XP facilitates a dentist in pursuing that worthy goal. But I'm going to suggest to you that practice success is a much more elusive thing, and there are not crystal clear avenues for a dentist that has clinical success but doesn't have the practice success he desires. There's not that many avenues that dentist can pursue, and so I hope the program today is somewhat enlightening on at least a couple of the facets to practice success in this multifaceted subject that I've been pursuing for so many years. So in order to begin, let's pose a few questions that will kind of get the subject off the ground. First of all, what is the obstacle to each and every one of your patients having the healthiest oral health possible? It ends up that in lecturing across the country to many study clubs and seminars and symposiums, both to doctors and staff, that the answer to this is almost the same every time. And although the answer that's given, and we'll discuss that a bit more in a few minutes, but the answer that's given is a factor, it really isn't the most important factor in determining the number of patients that seek out healthy oral health options. Secondly, which attribute of a clinician is most significant in determining the success of their practice? Now, again, most people would cite the fact that clinical excellence really is the factor that is most significant. But I'm going to suggest to you that there may be a separate skill set needed in order for a practice to achieve the level of success beyond what might be normal or reasonable for that given area. Thirdly, there's a question I want to pose that we're not going to be able to delve into a lot today, but the answer, I hope, will be somewhat obvious at the end of the program. That is, when is it time to work on your practice instead of in it? Certainly all of us go to our offices every day, and as long as the schedule is full, there might be a few problems that arise, but in effect, unless there's a problem, you just continue working the way you always have. I'm going to suggest to you that isn't the pathway to having the success you desire. Now, a few years ago, I was asked by a few of my staff members to participate in a game show. And I'm not much of a TV guy, but the game show they suggested I participate in was The Apprentice, because my father was a business guy. And really, I guess I'm lucky in that I've had a culture of being brought up in solving business problems. Well, in watching The Apprentice, after watching it a few times, I figured out that there is a common denominator to success in the business problems that they pose. And so, relating that to dentistry, let's play apprentice dentistry for a minute. We're going to use this diagram to illustrate what I hope will be the theme of the program today. And so, in our profession, how many people need the services that we have to offer? I'm going to use that as the upper portion of this hourglass. How many people really need what we do? And I'm going to suggest to you that people with teeth need us, people without teeth need us. And certainly in North America, where such a aesthetic consciousness exists, I'm going to suggest to you everybody needs us. So the number of patients we have feeding into our dental system, our dental pipeline, if you will, is almost unlimited. We have almost a unique business opportunity compared with the rest of the businesses out there, in that we have an unlimited supply of people really needing or wanting our services. Secondly, what's our ability to treat those people in need? How many people come to your office and say you have no idea what you're going to do with them or how you're going to treat them? Now, certainly you might need the help of a colleague in order to provide the best services possible for that patient. But I don't think our skills are really limiting the pipeline of success. Rather, I think there's a separate skill set, this limiting factor or bottleneck, that is where I focus my attention, and that's really where we're going to focus our attention today. And again, what is the obstacle to patients getting from wanting and needing our services to having that completed? And delving into that rather significantly. Now, using a different business model, there's a strategic planning tool called SWOT, Strengths, Weaknesses, Opportunities, and Threats. And that tool is used to make sure you're focusing your attention in a business situation on what is truly going to be effective results. And so to apply that to our little image here, we're going to start off again. Our strengths really are our clinical skills. The clinical skills the North American dental profession provides patients gives them results really beyond what they believe are possible. Going around to weaknesses, and weaknesses are what we have control over. There's what can we do personally to open up this pipeline, if you will, to success. The opportunities we have certainly lie in the number of patients we have available to us. The treatment options we can now offer are ever expanding and increasing, and so there's a huge opportunity out there. Now I'm going to pose threats as being the other side of this bottleneck, and those are extrinsic factors, such as limitations posed by third-party payers, limitations posed by maybe the corporate dental model, limitations posed by government intervention with the mid-level providers, etc. So this bottleneck isn't just something we have control over. There's extrinsic features which we may not have true control over, but I'm going to suggest to you by opening up the weakness side, we can minimize the threat side. So using this SWOT model, I'm going to suggest to you that we can open up the pipeline quite a bit. Now, in order to, again, introduce this subject, I'm going to suggest to you that the skills that got you to this point in the success of your practice may not be the skills that you need to take you to the next level. And to use that as an example, you start the first day of your practice, and you start off with 1 patient, then 5 patients, then 20 patients, and so you kind of picture this growth being a trajectory up based on the longevity of your practice. But those of us that have been in practice for a while certainly know you reach a plateau, and that plateau can be created by these extrinsic factors, maybe just limitations in the area you practice in. There are limitations in the present system. I mean, will clinical skills, ever-increasing clinical skills, get you past this plateau? I'm going to suggest to you it won't. That it might create what we call the super dentist, in that the more clinical skills that they possess in specialty areas of orthodontics, endodontics, implantology, that kind of thing. There's nothing wrong with pursuing that, but does that really make a practice successful? And I'm going to suggest to you it really involves a separate skill set, and that's the bridge. That's the bridge from clinical skills to practice success, and it's this separate skill set that is going to be necessary to take your practice to the highest levels. That's the subject we're going to be speaking on today. So we're going to attack the weaknesses. The threats we're not going to worry about, although recognizing they exist. Now, in order to do this, we're getting back to the apprentice kind of business model. How do companies grow? And if you get outside the dental world, and that's really what I try to do, is get outside the dental world and bring concepts that apply to business and bring them into the dental profession. So how do companies grow? One option is to develop an entirely new product line. That is something totally unique, totally new, and that involves development, marketing, implementation, and really difficult to do in dentistry, at least from a patient's perspective. Your office might offer, say, a CIRAC, and that's a new way of delivering a product they're already getting, but to a patient, is that really a new product line? And I'm going to suggest to you, by my own surveys with my own patients, it's not. So really, developing a new product line is not a way a dentist can increase the success of their business. A separate and very effective way is to question the assumptions in your present business model and really do what you're presently doing, but better. Again, let me repeat that. Do what you're presently doing, but better. Now, you're going to say, how do I do that? The way I practice is the way I practice. But I'm going to suggest to you that's really not true. You make many assumptions. Assumptions about your patients, assumptions about what their perceptions are, that really limit your practice. So let me give you a few examples. Really, an assumption is used because it is the path of least resistance. An assumption is basically something that's assumed to be true with zero facts to support it. To give you an example, a shoe company sends 2 marketing scouts to a region of Africa to study the prospects for expanding their shoe business. One scout reports back, situation hopeless. They don't wear shoes. A separate scout reports back triumphantly, unlimited business opportunity. They don't wear shoes yet. And that's the assumption that limits this business opportunity, and I'm going to suggest to you there are many, many of these assumptions in dentistry. Let's give you a couple examples. Again, why do we make assumptions? It's the path of least resistance. So, in this assumption thing, how do you reduce these assumptions? You ask more questions and more correct questions. You listen, listen, listen. Communication is one of the tools that I'm going to suggest to you is an attribute a successful practice needs to acquire. It may not be the most important one, but it's certainly high up there. And communication involves many times, more times listening than speaking. I mean, why did God give you 2 ears and 1 mouth? So listening is an important way to reduce assumptions. And finally, keep reviewing every system you have in your office and question everything. So let's give you a few examples of assumptions you might be making about your patients in today's economy. Candy presents to your office with a chief complaint of, I want to find out about getting my tooth fixed. Now, I'm not going to give you the details about Candy, but I want to give you some basic background. Candy presents unemployed, dressed in blue jeans, healthy in appearance and in medical history, and has no insurance. Now, she's unemployed and has no insurance. She wants to find out about getting her tooth fixed. What assumptions would you make about Candy? Now, I've posed this question to many study clubs around the country, and it ends up that it comes all the way from, what assumption would you make? She can't afford treatment. What assumption would you make? That she's self-conscious about this and is desperate to get it fixed and has no way to pay for it. That money is the obstacle. I'm going to suggest to you, after not having the time to develop this case the way it should be, it ends up Candy is dating a guy that owns his own business and wants to have Candy be a sales representative for him in that business. And her boyfriend has unlimited resources to get Candy's mouth fixed. So a question might be, in looking at this, really asking less about money and saying, Candy, which tooth are you interested in getting fixed? Because in reality, a clinical examination might reveal that more than one tooth needs to get fixed when she implies a tooth needs repair, and you in clinical examination might find many. And so it's almost like they don't wear shoes, or they don't wear shoes yet. And so when Candy asks about getting her tooth fixed, you could really turn the question around to her and saying, which tooth do you want fixed? Because there may be many. Let's go a different example. Tony, 37 years old, presents with a chief complaint of, I want to get my teeth fixed. Now it ends up Tony has a vertical fracture in his central incisor, and that tooth is hopeless. Now, what assumptions would you make about Tony with this history? He's divorced, recently moved into the area, and states, I have good insurance. Now, somebody comes to you and says, I want to get my teeth fixed, and I have good insurance. What do you assume about that patient? Well, many people would assume that he's going to have insurance be what decides what treatment he pursues. And I'm going to suggest to you, in this case, Tony's a weightlifter, great-looking guy. And when he tells you he has good insurance, what he's trying to say is, I want the good stuff. I really want my teeth fixed properly. And so it really doesn't mean a limitation in treatment. What Tony is saying is, I really want the best options you have available. He just doesn't know how to say it. And so it ends up, Tony ended up getting, certainly his tooth fixed with implant prosthetics, but he had aesthetic crown lengthening. He had a number of aesthetic features added to the case, really because he wanted the best treatment options possible. He just didn't know how to say it. A different case, Leo presents. His wife made the appointment for him. And again, what assumptions would you make about Leo, looking at his dentition, knowing this history? Leo's been married for 30 years. He's a long-haul truck driver and has been 15 years since he's last had dental treatment. Now, I can tell you, without giving clinical details, Leo's teeth cannot be saved. And so when his wife makes the appointment, he's a long-haul truck driver, what options might you offer Leo? what assumptions would guide those options. And it ends up that with very thorough discussion with Leo, he revealed that his wife won the lottery, and his wife made the appointment because she wanted him to get the best treatment possible. And so Leo ended up with implant-supported prosthetics, both upper and lower arch. And if you made any assumptions about Leo and did not pursue it to the fullest degree, you might think that Leo's treatment options would be narrowed down significantly by his history. So I'm going to suggest to you that we make many, many assumptions about our patients, and we need to ask more questions, more correct questions, listen, and constantly review our systems. So what is the biggest obstacle to each and every one of your patients having the best oral health possible? Well, rather than answer that by assumption, let's go to an outside source. We're going to go to the foremost authority in sales in the world, Zig Ziglar. And when you ask Zig Ziglar that question, what are the obstacles to a sales transaction happening, he's going to give you 5. 1, no want. 2, no need. 3, no trust. 4, no urgency. And 5, no money. So out of those 5 things, which one do we focus on? Which one does our staff really address? So I'm going to suggest to you the money is always the issue. Where if you address the other 4 with a thoroughness and vigor and insist upon excellence in finding out the details about each and every one of those aspects, you're going to find the money is way less a factor than what you think it is. And I'm going to suggest to you it's way less of a factor, period. And so how do you develop these 4 other things? Today's program is not going to be able to allow us to go into the detail that this justifies, but certainly we can pursue the desire and how to develop that, and a little bit into need. So let's get away from the money and focus on the other 4. So no desire. I'm going to suggest to you that a want, a need, a fear, those are the keys to getting a patient to accept treatment. And to start an examination without that being fully investigated is basically a waste of time. So Dale Carnegie, back in 1936, wrote a book, How to Win Friends and Influence People. And the foundation blocks that he described in that book, I'm talking about the cornerstones of winning friends and influencing people, are these. Don't criticize, condemn, or complain. Give people a feeling of importance and praise the good parts of them. But the one I've highlighted here is the one that is the reason for this slide. That is, you get the other person to do what you want when you arouse their desires. Now, how do you do that? Can you do that in a dental setting? Well, I'm going to suggest to you there's a couple of techniques that we use that are very effective in doing that. One we call our video newsletter, and this is basically a PowerPoint that runs on a continuous loop that's got a monitor attached in our reception area. And this loop runs for about 45 minutes. I'm just going to give you a few slides out of that while I'm describing it. And so basically it's a PowerPoint that runs on a continuous loop that shows some before and after photographs of patients we've treated. It shows dentistry and how it's presented in the media, particularly with this systemic health, oral health connection. And so we have one of our staff members review current contemporary magazines and see when there's an article in dentistry. And so we'll bring that in to this PowerPoint presentation, and patients see that while they're in the reception area. And I can tell you it establishes one, because many patients at the time we do our clinical exam will bring up the fact that they've reviewed this, and it kind of proved as a teaser, for example. And you'll see why I bring this up in a few questions that I ask people as a routine part of our exam. And so you can arouse their desire by having your office setting set the stage for that. In effect, be the frame for the picture you're trying to create. And you have, not that the patients spend a lot of time in the reception area, but certainly you have their attention when they're there. And so to have magazines that are of travel and leisure, and have magazines that talk about furniture design, I'm going to suggest to you is crazy. What you should have in your reception area is health magazines, men's health, women's health, eating right, shape. There's all kinds of magazines that can be brought in your reception area that even promote this point even more. So our video newsletter is a continuous running PowerPoint that shows before and after cases you saw, not clinically descriptive, other than showing healthy, attractive smiles. And it runs in a continuous loop, again, for about 45 minutes so that you don't bore a patient or they don't see something twice. You also see on the cocktail table there's a book, Options for Your Smile. Another way you can increase a patient's awareness of the kind of dentistry you do by showing before and after cases of patients that you've treated that have aesthetic outcomes that are desirable. So I'm going to suggest to you that this before and after photo book can increase a patient's desire. A general dentist in our area, she's an outstanding dentist, does this through photographs in a reception area. She has before and after portraits, really, taken of patients that had maybe dental needs that were rather high, and after they've been treated. For example, the photo on the lower left is the UPS driver in our area, and he was born with 12 congenitally missing teeth, now has 12 dental implants, replacing them, filling in those spaces. And so her reception area makes it really obvious that you're in the right place, establishing a desire for that. And ladies know this concept because when they go to a hair salon and they're about to have their hair makeover done, what kind of magazines and what kind of photographs do you see in a hair salon? All the magazines are of different hairstyles. All the photographs are on the walls and whatnot are of different hairstyles. So they can go to that hairdresser and the aesthetician and be given the style that is most suitable for them. Now, we call this phase of our examination the emotional exam. And I'm going to suggest to you it starts with the first phone call. And again, we could spend an hour or two, and we do in our 2-day program, on phone skills and how to answer the phone and create the stage for this patient coming. But I'm going to suggest to you making notes of what the patient likes and dislikes about the dental care they've had up to this point, what the goal of their appointment is. You don't want to get into this extensively, but certainly the phone call is the first stage for this. Then at the exam appointment, when they've arrived, having them arrive with them being recognized by name. There's no reason you can't do that because certainly you know the patients that are arriving for new exams. In our office, we have our exams at 8 o'clock, 1 o'clock, and 1:30. Why? Because we're never late at 8 o'clock, 1 o'clock, and 1:30. So our first appointment in the morning, we know the hygiene patients. They've already been in the office, so we have their photos. The patient that comes in that's not one of those hygiene patient photographs must be our new exam. And so if you can recognize the patient by name, using their name, having the assistant greet them in the reception area, not by just opening the door and yelling out their name, but rather walking up to them, introducing themselves, and inviting the patient back to their examination. Having the assistant have some casual conversation with the patient many times is difficult because a patient wants to start off talking about their teeth. Well, I don't choose to enter the room when they're talking about teeth because I want to get to know them as a person first, which you'll see in just a few moments. And so then starts the emotional exam, this interview process. And I'm suggesting, again, how do you get past assumptions, ask more and more correct questions, and listen. And so that's really what the emotional exam is about. You want to understand the patient's short-term goals, long-term goals, fears and desires, and as well get a personality profile, which we utilize in our office. Now, it ends up human beings communicate on a very consistent way. To get to the highest levels of communication, you have to start at the bottom of this communication triangle. And so that starts off with phatic conversation, chit-chat. Next, you go to cathartic conversation, which asks the patient's opinions about things, what their thoughts are regarding this, that, or the other thing. Thirdly, you get to an informative phase of communication where you're really finding out more of the deep, dark secrets that they don't reveal initially. For example, Candy, when she came to us, did not reveal that her boyfriend was very successful and was willing to finance whatever dental treatment she desired. That did not come in phatic conversation. That came with informative level communication, which you only get to if you start with phatic conversation. Where you really want to end up in conversation is with persuasive conversation. That's where you get to express your opinion, your viewpoint on what they should do, and they'll many times listen because you've achieved the pinnacle, if you will, of this communication triangle. So again, in order to get to the top, you have to start at the bottom, and that means small talk. And at that point, you're adapting the patient's speaking style, their speed, their emphasis, You're trying to figure them out as far as personality and social style, learning about them, listening with your ears, but also with their nonverbal communication. The cathartic level of communication really allows them to share their feelings. What do they think about this? How do you feel about that? And that's where you have to turn up the listening skills. And that also means nonverbal communication, facial expressions, hand motions that emphasize your listening and your communication at its highest level. There's a skill called active listening, which is something we work on very much in seminars we put on. And hit the internet on active listening. You'll find a great deal of information on that. Now, again, Dale Carnegie wants you to arouse their desires. Now, in this emotional exam, you can do that by the questions you ask. And so in doing this, this is hard. This is as difficult as any surgery you're going to do if you're going to do it properly. So you want to understand want and need. And we're going to graph this out. High want, high need, low need. Now in this, what's an example of high want? And I would suggest to you, for example, a woman's daughter is getting married and she wants her teeth whitened for the wedding photos. That's high want. There's no question that patient's going to do that. And so you can understand that, you can bring that out. And with that, you don't need to dwell on showing them a lot of this, that, and the other thing to establish that want. What is low want? My wife made the appointment. So on that spectrum, you're going to treat these people entirely different in your interview process and maybe what kind of examination you give. High need is a long-haul truck driver that broke tooth number 29, and he pictures that tooth aching and paining and swelling when he's on his road to Oklahoma, not knowing the doctor is going to treat, possibly missing a couple days off work. And so to him, that broken tooth has got to be fixed based on need. Where low need may be, again, his wife making the appointment for him. So in this spectrum, if you look at it a different way, you're going to want to take want and need and put it in these categories. If somebody has low want, low need, they're basically wanting the minimum amount of care, an emergency type exam until they've acquired a higher want and need level. There's no point in doing comprehensive examination and treatment plans on people that have low want, low need. Somebody that has high need, low want is going to be able to do treatment, might have to be more insurance-based, but certainly worthy of an examination that would reveal what kind of needs they have. Somebody expresses some wants in that, that's going to be having a higher level of want. You're certainly going to want to delve into an emotional exam at a much higher level. But the ultimate place you want to go, and I'm going to suggest to you, the place you want to seek out in your interview, if you can get there, is a relationship-based examination with both high want and high need. I'm going to suggest to you there are systems to do that. So, a want, need, fear, desire. That's what you're after. Now, Andrew Carnegie is somebody I've studied rather extensively, and he had a saying a long time ago that said, you can't push somebody up a ladder unless he's willing to climb. What we mean by that is you can't get somebody to pursue a level of dentistry higher than what they picture them needing or wanting. Now, you can entice them to climb higher, but you can't push them. What do I mean by that? In some of the seminars I put on, I'll ask a staff member or an office group to convince me to have my teeth whitened. How would you do that? Can you do that? And most officers say you can't. Well, golly, you can't do that. And other officers will say, well, I'm going to educate you as to the benefits of tooth whitening. And I'm going to suggest to you, unless I walk in picturing my smile being more attractive than it is, I don't think a staff member or a doctor can really do very good at that. So what do you want to do? You want to entice them. You want to establish a desire, have them either walk in with it or acquire it through interview. And there are systems to do that. So how do you know if a patient's willing to support cosmetic or implant treatment? I mean, a partial denture is within the standard of care, and implants are within the standard of care. And yet one costs 10 times more than the other. How do you know which treatment to propose? I'm going to suggest to you, you ask. And you ask listening very carefully and as thoroughly as possible, making no assumptions. And so there's a system to this question sequence. Obviously, most dentists start off their examination with open-ended questions, but we want to get to an emotional level. You're going to start off saying, what problem are you having today, or how can I help you? And that you might go to, how long have you had this problem? But those are not emotional-based questions. Your goal is to get to how this problem has affected you. And maybe, what do you picture happening if this problem is not addressed or not treated? Because I'm going to tell you, if they picture pain, if they picture swelling, that's emotion-based. And case acceptance is an emotional issue. You're not going to convince me with data to pursue comprehensive dentistry. And so after you start off with your normal open-ended question, I'm going to suggest you steer them towards having an emotional attachment to them. How is this impacting you? Has this chipped tooth made you smile less? Do you feel self-conscious about it? That kind of thing. So get them to state a level of disability that has some emotional connection to it. Now, I've studied successful practices across the country, and successful practices really steer their treatment from fixing teeth to fixing mouths. They do comprehensive dentistry, comprehensive examinations, and so to shift a patient from coming in with a tooth problem into looking at it like we would prefer to do, meaning comprehensively, you have certain questions you can do to compose to get them to shift gears into a mouth-oriented thing. So I'm going to suggest to you questions, for example, what would you like to see happen in your mouth down the line? That's a question I pose to almost every patient, maybe except a 12-year-old getting a frenectomy. And really what I mean by that is, really, what's the goal of your treatment in my office? Now, many times they're going to say, well, what are you talking about? And I'll say, well, what are your thoughts about having false teeth, having dentures? And they'll go, well, I don't want to do that. And so then your goal would be to keep your teeth all your life? And that's something that they would then answer. And so what are your thoughts about dentures, having teeth in a glass? Now, if they say, well, geez, I'm not sure dentures aren't a bad deal. My friend has them, and you don't have to any more toothaches after that. And so you've got then a need for changing their mindset. And so for me, I have a set of dentures in the drawer right beside in our operatory, and I'll say, have you ever seen a set of dentures? And so many times they say no, and even if they say, no, I've seen a set, I'll bring those out. And many times I'll drop the lower one on the floor, intentionally, but not looking intentional, and I'll say, well, that's what happens when you stick your tongue out. Because patients have to understand that dentures aren't the solution, dentures are the problem. And it's your goal, doctor, to achieve that. So ask them what their thoughts are about dentures. Once you get them to say, I would like to keep my teeth all my life, then another question you could pose is, okay, let's pretend you're going to keep your teeth all your life. This is still just your emotional exam. You haven't done any clinical exam at this point. And so somebody says, I'd like to keep my teeth all my life. Great. Let's assume you can. Is there anything you'd like to see different in your smile from the way it is now? Now, realize patients have just come from my reception area that has before and after photographs of whitened teeth, straightened teeth, etc. I'm going to suggest to you, after having that, 80% of my patients say, I'd like whiter teeth. Now, when somebody says they'd like whiter teeth, what do they really mean? You're making an assumption if you get out the bleaching trays and the Zoom and that kind of thing, because I'm going to suggest to you that many patients that say that are really saying, I'd like a more aesthetic smile. And so, again, this is an emotional exam, and you don't want to make assumptions at this point. So there's a whole list of questions that are in my menu of questions, so to speak, and I'd be happy to send that to you. I'm going to give you my email address at the end of the program and can send you the menu of questions that I pose to patients to really get no assumptions being made in this clinical emotional exam. And so there's also questions that you can pose that for patients that don't reveal very much to make sure you understand. You're not pushing off the ladder. You don't want to propose treatment that they're not asking for, but you clearly want to understand what level of treatment they are asking for. So while you're doing this, you're looking at their smile, looking at symmetry, looking at discolored restorations, anything you think might interfere with the aesthetic outcome they desire. And so in looking at that, this is the time to ask, what are your thoughts about that dark filling? What about tooth number 12? It's got a dark amalgam. I see that tooth's a little dark. What are your thoughts about that? Oh, I've had that all my life. Doesn't bother me. Great. Move on. But if they say, well, geez, while I'm looking around, I'd like to know that you're right, that tooth is a little dark and I don't like it. And so this emotional exam, you've got no assumptions now. You really want to understand what their thoughts are, what their goals are, long-term in treatment. Now, this is a case that came to us really needing and wanting tooth replacement for congenitally missing lower molars. You can see in the photograph on the upper, they've got primary teeth there. And when I asked her, is there anything you'd like to see different in your smile from the way it is now, she said no. Now, I thank God she can't, there's not a billboard on my forehead that shows what I'm thinking, because I'm looking at this lady's front teeth saying, lady, your smile looks stupid. But I'm more gracious than that. I say, you know, I'm an expert on smiles, and I noticed your front teeth don't look like most people's do. And I said, does that bother you? And she said, I've hated that all my life. And I said, well, it's a rather small procedure to numb it and change the shape of the gum tissue and remove this little cord that's detached in an improper way. And it's a relatively small procedure to do that. And she said, I would like that done right now. I don't want to leave your office. I'll stay at lunch. I'll stay after work. I've hated this all my life. Now, this lady was 34 years old and has been going to a dentist most of her adult life, and that just never came up. And so it's nothing wrong with critiquing their smile while you're there interviewing them, if you will. Now, at this point, the bib is not on. The chair is not tipped back. This is a conversation, sometimes in the treatment conference room, other times in the operatory. But it's without a chart, without me making notes. I'm really just talking to them. My assistant might be making notes behind the scenes, but really it's to get to know them as a person with phatic conversation, chit-chat, talk about what they like, what they don't like, what I don't like. I reveal a bit about myself, so they'll reveal something about themselves. Then go to cathartic conversation where you're getting their thoughts on, you know, how has dentistry treated you in the past? Do you like going to a dentist? Do you find it stressful? Learning, having them share their thoughts and being empathetic, and obviously, again, nonverbal communication to support that. Then getting the informative things, questions I'm asking. And then finally, you'll get to a persuasive level where you get to share your opinions. So what would you like to see happen in your meltdown line? If they say, I want to keep my teeth, and I get almost every single patient to say that. And it might take a couple different lines of questioning to do that. Once you get that, then you want to delve into the next level according to Zig Ziglar. And that is establishing need. So you get the patient to say they want to keep their teeth, so then you have to get to establishing need. Now that's an interview skill. This is a clinical examination technique that you, your assistant, and the patient all participate in to establish need. Now I'm going to suggest to you that the clinical examination is not just about the doctor learning the clinical features that a patient presents with and describing a treatment plan accordingly. It's the patient learning what's wrong with their mouth as well. Because sick patients that think they're well don't accept treatment. Now, I'm a periodontist, and so most patients that come to me with periodontal problems have no idea that they have that severity of disease. I'm going to suggest to you, once you get patients involved with comprehensive diagnosis and treatment planning, they have to own their disease in order for the treatment plan to fly. So to bridge these clinical skills you have to practice success, want and need are a key component to doing that, because the patient will not support treatment they do not feel is necessary. So how do you do that? A clinical examination really establishes the need for the patient by explaining to the patient health, illness, differences, talking single tooth oral health issues versus whole mouth wellness, and prepares the patient for the degree of treatment needed. Now, what you're really doing is getting clinical data to support your treatment plan, but at the same time collecting clinical findings that allow the patient to be enlightened as to what treatment options they need in order to have their diagnoses addressed. So in effect, get the patient to own their disease. So this is a little diagram I use to explain this concept. Now, at the far left is what the doctor's level of discovery is during the exam. In the middle is the patient's perception at the time of the exam. And then finally, what the difficulty is of the treatment conference that results from these different levels of perception. So if a patient comes in basically with a healthy mouth, the doctor does an exam, this patient's doing well. The patient feels they're doing well. That treatment conference is easy. Leo, when he came in, he knew he was in trouble. So our clinical exam revealed certainly he has multiple dental issues. But he knew he hasn't been to a dentist in 15 years. He knew he was in trouble. So that treatment conference is easy. It is a challenge when a doctor sees that the patient's mouth is doing well, but the patient perceives there's something wrong, maybe a bad taste from a certain area or bad breath, and we're not seeing anything wrong. That treatment plan or that treatment conference is somewhat difficult. But the real challenge, the big difficulty is when the doctor sees multiple factors that are not conducive to oral health, and the patient thinks everything's fine. Let's use parafunction and the lack of anterior guidance as an example of this. If a patient comes in with anterior guidance lost and parafunction being an issue, they don't many times have any symptoms, but they're breaking cusps off, they're needing crowns, and they're headed to nowhere. So the doctor there perceives a high level of dental disease or dental problem, and the patient's not really perceiving much. That's going to be a very difficult treatment conference. So what you need to do at that point is at the exam, not by educating them after you've done the exam, but within the exam, have an exam technique that assures the patient will own their disease, discovers the level of oral health they started with, and then what they end up with. So at the beginning of your exam, many times I'll start off with, if I were to ask you your oral health on a scale of 1 to 10, 10 being outstanding, 1 being very poor, prior to your exam, where do you think your oral health is at? Most patients will give me a 7 or an 8. But then doing the exam that I'm referring to, and then ask them this question again after their exam, of saying, now, after our exam, where do you feel your oral health level is at? 1 to 10. Most often they'll say 2 or 3 after the kind of examination technique I'm referring to, if in fact they do have oral health issues. So there's an exam technique that I'm going to describe to you that really is maybe a bit more involved than this program will allow you to be fully skilled at, but will at least give you the insight that you know you don't know, as opposed to now you think, hey, the way I do my exams is fine. So I hope you understand that there's a technique to clinical exam that allows you to have higher practice success by just modifying that technique. That examination technique involves the assistant prompting the doctor for clinical parameters. The doctor explains to the patient what they're looking at and why, what healthy is, and the range of illness from that healthy parameter, then tells the assistant the level of health the patient is at within those parameters, then finally summarizes the patient the results of that. So what are you doing? You're telling the patient what I'm going to look for and why, here's what I see, and here's what I saw. And that is the way to set the stage for a patient owning their disease. So you need to do this all in terms the patient understands. They do not understand abfractions, parafunction, caries. They don't understand that. So you and your dental team should take your clinical exam form and have every clinical word you use brought down to a 5th grade level. Gum loss as opposed to recession. Decay being replaced for caries or leaky fillings. Patients understand those terms. And so to get away from the dental terminology and using terms patients understand. Now, to give you a description of this, let's go through at least some part of a clinical exam. Now, when I start my clinical exam, I'm going to go through an extra oral exam. So I'll start off after the chair has been tipped back, and by the way, I ask for permission to do that. After I do our emotional exam, we have a little gel pillow we put behind their neck. I'll tell the patient, listen, I've got a gel pillow for behind your neck that's going to make it more comfortable for you. And is it okay if I tip the chair back? And in doing so, the patient becomes more at ease. They know this is going to be an interactive session. So when I start palpating for lymph nodes and muscle tonicity, that kind of thing, I'll just describe to the patient what I'm doing. I'll say, I'm going to start our examination today by looking for any lumps or bumps that don't belong. Oral cancer is really not a common problem, but I want to make sure there's nothing going on that we don't know about. And so as I'm doing that, I'm feeling around and describing, setting the stage for this patient-involved clinical exam. They're not allowed to have headphones on. They can't be reading the newspaper. They're not going to be talking on their cell phone. It's critical. I can't overestimate this, that it's critical the patient be involved with this clinical examination. Now, so again, before I start my intro exam, I'll make sure they're involved with this clinical exam and listening to what I have to say. So once I do that, this examination is like a symphony or like a play, because the minute I stop with that description, I start looking in the patient's mouth, my assistant will prompt me with, Dr. Setter, are there any missing teeth? She'll say that to me, then I describe to the patient. Mrs. Patient, an adult, typically has 32 teeth, but 4 of those are wisdom teeth. So I'm going to look in your mouth and describe and look for any missing teeth you might have. And then I'll look through and say, Lisa, who's my assistant, Lisa, there are the 4 wisdom teeth are missing, but also tooth number 30 is missing. Mrs. Patient, how long have you been missing tooth number 30? And she'll say, 5 years. Fine. The assistant then automatically prompts me into a couple of questions related to that missing number 30. Now, if there was no missing tooth other than the wisdom teeth, this second and third question wouldn't come up. But the assistant, knowing there's a missing tooth, would say, Dr. Setter, is there any damaging movement caused by the missing tooth? And I'll say, Mrs. Patient, when you have a tooth missing, it's not uncommon for the neighboring teeth in front and behind it, and also the tooth above it, to shift. And the shifting of those teeth can cause further damage to those adjacent teeth, because the load on those teeth becomes more adverse, or it can become more difficult to clean the teeth or food impactions. So I'm going to look to see if you've had any damaging movement caused by those missing teeth. Then I'll look in her mouth and say, Lisa, tooth number 3 is hypererupted by 3 millimeters. It's dropped down. And the neighboring tooth number 31 has, the tooth just behind that space, has tipped 5 degrees. Mrs. Patient, some damaging movement has already started from that tooth you're missing in the lower right. Lisa then prompts me, Dr. Setter, is there any bone loss caused by that missing tooth? Then I'll suggest to the patient, Mrs. Patient, when you have a tooth missing, the bone in that area stops getting any exercise, and that bone can start shrinking due to a lack of function. So I'm going to look in your mouth and see if your jawbone is having any loss due to that missing tooth. In looking at her mouth, I'll describe to Lisa, my assistant, Lisa, there's been 3 millimeters of bone loss from the crest or the top, and then 2 millimeters of buccal or a cheek side bone loss. Mrs. Patient, that bone loss has already started from that missing tooth. And so you'll go on all your clinical parameters using this technique of describing what normal is, what abnormal is, what unhealthy is, and then explaining to the assistant what you find, then reiterating to the patient on each clinical parameter what you're seeing. The one I like the most is related to periodontal disease. We'll talk to the patients about gum loss, and that when you lose gum tissue, you're really losing the foundation for your teeth. And for somebody that wants to keep their teeth all their life, this foundation loss is a real issue. And when we discuss, for example, we're going to do a charting of periodontal pockets, we'll go through and say, Mrs. Patient, your mouth and my mouth are full of bacteria. And the gum tissue has a major job in performing a seal around the neck of the tooth to prevent the bacteria that's in your mouth from getting under the gum, destroying the foundation around your teeth, and also having those bacteria get access to your bloodstream where they cause systemic health problems. Now, because I've had in my reception area some magazine articles that talk about systemic oral health issues, that probably alerts her to a higher level. Then I'll go through and explain the fact that we're going to make some measurements around your teeth to assess this gum tissue seal, if you will. Now you notice I'm using terms that are not dental related. These are patient-friendly terms. So we're going to use some measurements to measure this gum tissue seal. And so 2s and 3s, that's normal. That means a good seal. 5s and 6s, that's a problem. Gum tissue's leaking. If it gets to 10, you're probably going to lose the tooth. So do you have any questions about those numbers? Patient will typically say no, and then I'll start reading the measurements off. But I'm going to do it more emphatically when these numbers get higher. If it's 2s and 3s, just read them off. But when it gets to 5s and 6s, you're a bit more emphatic. Whether 3, 6. Lisa, did you get that 6? So the patient is not allowed to not pay attention to that. So by the time you get done with all their natural teeth, by the end of that, if they have periodontal disease, they're starting to sweat. They're starting to get upset with the fact that they know they've got a problem. And at the end of the charting, you'll conclude the fact that this is patient. The gum tissue leakage I'm describing is commonly known as periodontal disease or gum disease. That's one of the main reasons adults lose their teeth. And so you mentioned when we were talking that your goal is to keep your teeth. And so this is one problem we're going to need to address when we develop your treatment plan. Now, there's an overall concept within our whole office, and I'm sure yours, or if it's not there, it needs to be. And that is, patients don't care how much you know until they know how much you care. And so I'm going to suggest to you this practice success comes from an office aura that probably justifies another webinar similar to this on how to set the stage for a staff commitment, the office amenities, the music, etc., all showing it's all about them. So that needs to be an overriding factor when you're describing this emotional and clinical exam. Now, in the top 10 practices in North America that I studied, that meaning the top most successful production per hour practices, they have a number of features in common. But beyond the emotional exam and the clinical exam that has the patient own their disease, one of them is the 2-appointment sequence. So we make sure the first appointment's about the problem and the second appointment is about the solution. And so we commonly don't give the treatment plan at the first appointment. That commonly is done at the treatment conference appointment after we've collected more data, photographs, radiographs. We use CT scanning very often in our prosthetic cases, in our perio cases. And so we collect the data and then at the second appointment go through that. And no treatment is discussed at the first one unless it's a one-tooth problem. If it's a one-tooth problem, a one-tooth solution is offered up, and that then is done at the same time. Now, many in general practice will ask, well, how do I fit this exam in when the patient many times is expected to see the hygienist that same day? Now, I don't know how your clinical protocol is, but I would have your phone, first person on the phone, find out what the patient's expectations are at that first appointment. Many times a patient will call as a new patient and ask for a cleaning appointment. I'd like to set up a cleaning appointment. And rather than give a bunch of litany as far as, well, before you get a cleaning, you need to see a doctor for x-rays and a comprehensive examination, I would pose some questions to that patient saying, one, how long has it been since you've been to a dentist? Are there any concerns you have at this time? Is there an urgency in getting your teeth cleaned? Is there a social event that you have upcoming that your teeth are in fact not attractive because they haven't been cleaned in a while? Because we want to make sure our first appointment with you satisfies your needs. But I would tell you that we certainly want to make sure we understand the nature of any dental problems you have and want to offer a thorough solution to those problems based on what you'd like to see happen. And that, so let's make sure we know what the patient expects before that appointment. So in general practice, what we find is that by knowing ahead of time what the patient expects, many times when they ask for a cleaning, what they're really asking for is to become a new patient. You're making an assumption in that a patient is needing their teeth cleaned at that first appointment. So the first appointment, including the emotional exam and the clinical exam where you get the patient to own their disease. The second appointment is about the treatment conference, and we'll have to go into that at another time. Now, you see these messages I'm putting up on the screen. Negative experiences and feelings have cost. Positive experiences and feelings have value. You know, the way to get money to be the less important thing is to make it the less important thing. You know, I really do believe if you envision a patient not accepting treatment, you're correct. They won't. And I really think if you envision them doing the treatment, you have positive energy about that, many times they will. So life is somewhat of a self-fulfilling prophecy. So if your team believes that you deliver dentistry that changes people's lives, That's the motto of our office. I'm going to suggest to you that you can make the financial aspects of treatment be less because the positive experiences and feelings they have in their office, in your office and mine, can produce value beyond what they've experienced in some of their offices. Now, dentistry is practiced the way you perceive it. You look through your own little keyhole. And one thing I do at our seminars is we'll have the audience cross their arms. And the way you cross your arms is not described in a textbook or you're not instructed in it. You do it just the way it feels most comfortable for you. But if I ask you then to cross your arms the opposite way, that feels very uncomfortable, but it's just as effective in crossing your arms. So I think the way you cross your arms is many times the way you practice in your office. You do the interview and the examination the way that maybe your dentist did it to you or the way you were taught in dental school, when in fact there probably is a more effective way in making sure no assumptions are being made and you develop, you arouse the patient's desires. That's how you get them to do what you want them to do. So I'm suggesting to you, expand this keyhole in the way you practice your dentistry and work on your practice instead of in it. And that's a way to have this bridge between the clinical skills you acquire and your practice success increasing. Now, this is a very famous image, again, showing assumptions or perspective. Some people look at this and see an old woman with her chin down at the lower end of the photo, or the image, where others see a young lady with that area that was the elderly woman's chin being the young lady's neck, and she's turned away. And so the point of my bringing this up is the way that you perceive your practice going, perception is reality. So if you think the biggest obstacle to your patients accepting treatment is money, it in fact will be. But if you make the biggest obstacle to your patients accepting treatment is your ability to arouse their desires, your office aura being a setting that makes them want to participate, want to come and get involved in what's going on in your office. If you arouse the want, you arouse the need, the others are establishing trust and establishing urgency. Trust is not difficult in the dental profession. Our profession is well respected, and trust has to be earned, but it doesn't take a long seminar to get that trust established. And finally, urgency. Urgency is something that no dental problem gets less as time passes. And so having some verbal skills to bring out that urgency is a way to reduce the financial concerns that you have regarding patients initiating treatment. I have a very successful practice in Michigan, and I would suggest to you that this area is described as the epicenter of disaster as far as the economy. But in utilizing the basic concepts that I propose today has allowed the economy to be independent of the practice success we've achieved. And it comes through realizing the obstacles are more within your control than you would envision. The second question I posed is, answer this one. I think the obstacle to success may be you. And if you don't utilize all the tools you have to develop a patient's desires, a patient's want, need, trust, and urgency, then you're the obstacle to their success. And that listing that Zig Ziglar gave us is your guide path. The second question I posed is, which attribute of a clinician is most significant in determining the success of your office? And rather than pursuing higher and higher and higher clinical skills, I'm not suggesting that's wrong, but rather than do that, pursue leadership. There's many books on that. This webinar could continue on with maybe that being another topic we discuss. That leadership is the skill that most people feel is, how do you get people to follow you? Being a leader. You want your patients to follow you. You want your staff to follow you. You'd like other professionals to follow you. So I'm suggesting to you developing leadership is critical. When is it time to work on your practice instead of in it? All the time. Your practice is constantly evolving. The business environment you're in is constantly evolving. So I hope this webinar has helped you with some ways to bridge your clinical skills with practice success. Realize it's a multifaceted subject, and today we discussed two of them, want and need. If you have any questions or comments, you can contact me at my email address that's posted. I thank you for joining us this evening, and look forward to speaking to you again.